Hysteroscopic myomectomy for submucosal type 2 fibroids with cold enucleation technique and complete fiber extraction using a double lumen intracervical cannula. The purpose of this video is to introduce a new double lumen intracervical cannula designed to allow a single-step hysteroscopic myomectomy with non-fragmented complete fiber extraction after cold enucleation of submucosal type 2 fibroids, avoiding complications related to the use of energy and hyposmolar solutions. We present the hysteroscopic surgical procedure performed in a 45-year-old patient with abnormal uterine bleeding consisting of poly and hypermenorrhea, non-responsive to medical treatment caused by 3 FIGO type 2 submucosal fibroids of 17, 15, and 13 millimeters with more than 80% of intramural component. Transvaginal ultrasound images demonstrate 3 fibroids with submucosal component. These were numbered from the uterine fundus towards the isthmus. Fibroid number 1, anterior fundal 17 mm type 2 fibroid. Fibroid number 2, posterior corporal 15 mm type 2 fibroid. Fibroid number 3, left lateral ischemic 13 mm type 2 fibroid. Before the surgical technique, it's very important to have an extremely clear ultrasonographic fibroid mapping before performing the hysteroscopic surgery for fibroids with a predominant intramural component. Disadvantages of conventional hysteroscopic resection for FIGO type 2 submucosal fibroids. Fibroids intramural component technically difficult to access. Partial resection that frequently needs an additional hysteroscopic surgery. Potential thermal damage to neighboring healthy myometrial tissue. Potential complications related to the use of hyposmolar uterine distension media. Hysteroscopy was performed using the Vetocchis hysteroscope with a single flow 3.9 mm sheath and normal saline as uterine cavity distension media. Fibroids were properly identified according to hysteroscopic findings and previous transvaginal ultrasonographic mapping. Fibroid number 1 of 17 mm with a 20% submucosal component. Fibroid number 3 of 13 mm with a 15% submucosal component. Fibroid number 2 of 15 mm with a 10% submucosal component. As the illustration shows, with the telescope's distal end bevel, pressure is applied over the reflection angle between the fibroid and the endometrium in order to access the fibroid's pseudocapsule. Blunt dissection is performed in this plane with the hysteroscope's tip always under direct visualization until complete fibroenucleation is achieved. Fibroid number 3 in the isthmic left lateral wall is enucleated using the described technique. As you can see, once the pseudocapsule is ruptured and with a subtle pushing maneuver with the hysteroscope's tip, the fibroid bulges into the uterine cavity, facilitating the completion of the fibroid's enucleation. Constant visualization of the surgical plane is fundamental to avoid uterine rupture, which is not only considered a complication of this surgery, but also a reason to cancel the hysteroscopic procedure due to the loss of intrauterine distension pressure caused by the fluid loss through the myometrial defect. Fibroid number 1 in the fundal anterior wall is enucleated. Fundal fibroids pose a further challenge for blunt enucleation since the pushing maneuver from the fibroid's base with the hysteroscope's tip is not feasible. This blunt fibroid enucleation is a hemostatic procedure. If adequately performed, no considerable bleeding occurs when keeping the hysteroscope's tip in the appropriate surgical plane, the pseudocapsule. As you can observe, fibroids are enucleated but not completely released from the fibroid's fovea, hoping that they will not be moving loosely and can be easily grasped once their extraction is attempted. Fibroid number 2 in the posterior corporeal wall is enucleated. Adjacent healthy myometrial tissue is kept intact without any thermal-related injury. Its anatomic and functional integrity is preserved, which is of crucial importance for fertility patients. All fibroids must be enucleated before cervical dilation is performed. Otherwise, distension of the uterine cavity wouldn't be optimal due to transcervical fluid loss. Visualization would be poor, and the enucleation maneuver would become technically difficult. All 3 submucosal fibroids were successfully enucleated without detaching them from the fibroid's fovea. Now they are ready for complete fibroid extraction. At this point, as the illustration shows, cervical dilation was accomplished with Heger plugs, and extraction of the fibroids performed with the parallel and concomitant insertion of a laparoscopic tenaculum forceps in order to grasp and pull out the fibroids under direct visualization. To overcome the challenge of having an excessive retrograde fluid loss through the dilated cervix during the fibroid extraction, we designed a cylindrical double-lumen metallic cervical cannula that adapts itself perfectly into the dilated cervix. This device has 2 lumens through which the Betocchis hysteroscope with a single flow sheath and the laparoscopic tenaculum forceps can be introduced into the uterine cavity simultaneously, keeping these 2 aligned for adequate visualization. Enucleated fibroids are extracted starting from the lowest and ending with the highest fibroid in the uterine cavity, with the purpose of avoiding lower fibroids getting in the way and causing an obstructive effect. Fibroid number 3 is extracted with the laparoscopic tenaculum grasper under direct visualization. Fibroid number 2 is extracted. Fibroid number 1 is extracted. Complete and unfragmented fibroid extraction is achieved without any residual pathologic tissue left on site. This was an ambulatory surgical procedure with a total operative time of 32 minutes, which seems to be considerably shorter when compared with conventional electrosurgical techniques. The total amount of normal saline distension media used was 800 milliliters with a liquid balance of 50 milliliters. No hyposmolar distension media was required. No surgical or anesthesia-related complications occurred. The patient's postoperative course was uneventful with minimal postoperative pain, high patient surgery-related satisfaction, and complete normalization of menstrual cycles. Postoperative transvaginal ultrasound images demonstrate a complete restoration of the endometrial cavity anatomy with appropriate endometrial thickness and appearance, as well as normal myometrial ultrasonographic characteristics. Conclusions. Hysteroscopic complete unfragmented type 2 submucosal fibroids with deep intramural component extraction can be performed in a single intervention. The double-lumen intracervical cannula allows this technique, avoiding the need for electrosurgery and its related complications. This surgery can be performed with the use of a diagnostic hysteroscope widely available worldwide in gynecologic practices. Thank you.